Hello and welcome to another show that we have, Think Big, Act Now. Today, I am really happy to welcome to the stage Stephen Haken from Odelle and my co-host today, as always, Richard from HCI. Richard, first and foremost, how are you doing? You all right?
I'm very good, I'm pleased to say. Beautiful week here.
It,
Looking
it is,
good, keeping
it is
busy, making things happen. So how about with you?
excellent stuff. It is stunning here. And today we do have the one and only Stephen Haken from Odelle, and we are really grateful for his time. And he's going to give us an international flavor to some of the challenges that are facing health services, and in the view that the NHS can learn from what's happening in mainland Europe as well. So, no further ado, Stephen Haken, how are you doing, and welcome.
Very well, thank you, Douglas, and thank you very much for this kind invitation, Richard. I'm Stephen Haken. I'm a director of Odelle Technology. We've been helping medtech, biotech, and pharma with market access and reimbursement and government affairs for over 20 years. We're based in France and the UK.
Wow. So you certainly that France, the UK as well. So you are crossing the pond, as it were. So what sorts of challenges are you finding in mainland Europe, particularly around France, in around health and the pandemic in general? What sort of challenges have been brought to the surface?
I think what's happened well, I'll talk about the continent of Europe. We're essentially organized through regions. So Spain has 17 autonomous regions plus 2 autonomous cities, as you probably know. France has a territorial structure, as does Italy. Germany, of course, has a state structure that finances health. And if you look at the pandemic, COVID has been asymmetrical in its devastation across all of these territories. So in the beginning, it was quite nobody really knew what to do, and mistakes were being made. I think that's all. I think we learn from mistakes, so that's good. We just progress. We don't look for blame. We just get on with it, and I think that's an important thing to learn in life. It's you there are numerous scenarios that played out in each country, but what has happened is that those people who were running territories, clinical commissioning groups in all of these countries that run various regions of Spain, France, Italy, Germany, have been the successful ones have been those people who've found quick digital solutions to overcome backlogs with waiting lists, who've been able to shift populations away from hospitals and do things remotely. And they've been very quick in putting together, meeting patients where they are in their home. They're the people who I feel have been the most successful over the past few months.
Brilliant, because again, this is we're taking the pandemic as an impetus to bring around digital solutions.
I think so.
And yeah, and leveraging that in a very positive regard to empower patients. So are you seeing that a lot of the barriers that were traditionally there, in terms of frameworks, commissioning groups, they're changing their way of behaving to enable some of these digital solutions to be brought in at pace?
Yes, they're behaving positively towards digital evolution. They were looking at it as an experiment before, but they quickly realised that this opportunity for digitalisation has enabled them to provide a better framework for patient movement. So I think that what I have seen in Spain in perhaps half the territories is a digital solution that has enabled patients to stay away from their tertiary care centres and operate through their general practitioners, their primary care centres. And it's enabled the marriage of their primary care data and their tertiary care data to come together. And it's been able to do it quite inexpensively. And that's been a very successful move in France with the territories here. But if you look at what's happened, a number of digital solutions have also entered into outcome-based contracts. They've entered into them on financial terms, on I would say coverage of evidence terms with pharma. And the other thing I think that's important in answering your question is there's been a lot of interesting stuff going on with pharma and digital health.
And you talked there about outcome
Yes.
models. What are you seeing then? What sort of?
Well, so with performance-based outcomes, reimbursement in the pharma world, what's happening is that the outcomes are being measured and in the community. So there's a couple of examples with new chemotherapy that's happening for breast cancer. You'll see it in the United Kingdom. There's there's chemotherapy that can be done at home for a type of breast cancer. So the nurse arrives or the administrator arrives. It could be a pharmacy technician as well in some countries, arrives at someone's home. It's a dose delivery system that they use. So there's also, with the dose delivery system, there's a reporting module associated with it. And the particular pharmaceutical company who's associated with that are recording outcome measures. So there's if you like, it's a complex registry. Now, all of that registry data is shared not only with the pharmaceutical company and with the medicines agency in that country, but it's also shared with the general practitioner. It's also shared with the health economics unit, and it's also being shared by a group of researchers who are associated with outcomes-based evidence. So if the outcome of that patient is positive, then there is a fee associated with that for the pharma benefits. So yeah, they're actually investing in their own evidence is what they're doing.
Wow. And are you seeing that in digital
Yes, so they
interventions as
need a
well,
digital
just in the
solution to
same
manage
way?
it. So you're needing a conduit, if you like.
Yeah.
And that's what's always the biggest problem I think we've had for years is we've always asked people to meet us at our place. It
Yeah.
doesn't work anymore. We want to meet people inside their homes. That's where they live. That's where their health is. Their family, the people they love, the things that they enjoy doing. That's where their health is. And so we've actually got to meet them on that in that environment in order to have a profound effect. So, and the digital solution is something that's left with the patient. So she can report back accurately on a daily basis or by hour or by the hour.
Excellent.
Yeah.
Excellent. And we're definitely seeing over here in the UK as well, this big rise of outcome-based measures that can only truly be achieved with digital solutions, because not only do you have the free flowing of data going across different systems, you cannot do that on any paper-based system. Uploading is redundant. And again, using the pandemic to drive through a solution that enables the digitization of health information, then you can start appraising outcomes.
Absolutely, and outcomes are probably what healthcare systems are very interested in. I mean, for a long time in some countries, your postcode was more important than your genetic code.
Yeah.
And that's true in, I won't say which countries, but it is profoundly true. And a digital platform helps us overcome some of those issues.
Yeah.
And it also helps us overcome the management of chronic diseases as well. So there have been a number of successful installations I can talk about in Germany and in France that have received reimbursement. So they're getting paid for per procedure and per encounter very successfully through a reimbursement model that the company and the payer and the territory have organised collectively.
But that means that the reimbursement model is reinforcing the right behaviours, not
Yes, not
acting.
perverse behaviours, because in the past, some countries have had quite perverse reimbursement systems. So there are examples in every country. So in some examples in the United Kingdom and elsewhere, a hospital was rewarded financially for a patient visit into the hospital. So you think about the footprint associated with that and the traffic and the miles, and you think, well, this is not the right thing to do for the patient, nor is it really the right thing to do for anybody. So now the reimbursement is to keep people away. So the big integrated care systems that we're developing in the United Kingdom were the old strategic health authorities, I think, in effect. The old SHAs worked.
Yeah. In a practical sense, some people may say, yeah, but we've got staff shortages globally. There's a shortage of health. So if we're going to have them fragmented and disparate all around traveling to people's homes, that makes them less efficient. So we don't have enough staff when patients are coming to us. How are people coping with that sort of conundrum, that tension, should we say, between the two demands?
In answer to staff shortages, I suppose the formulation of a problem is more essential than the solution often. So you've really got to frame the problem correctly. You've really got to analyse what the problem is. Is it really staff shortages, or is it the way we're using our staff currently? Are we using nurses I mean, nurses to me are an underutilised resource, and we don't pay enough respect to nurses. I think it's a vocation with a pastoral content that has been undervalued for years, and I think a lot of these good people should receive extra additional training, and be recompensed for it. I even think we're not recompensing surgeons and other physicians and GPs sufficiently for the time and energy that they put into their profession.
Yeah, but there's a view, isn't there, that something like 40 to 50% of consultants' time is on admin.
It is.
And
it doesn't make
no,
it makes no sense, does it?
And people not working at the top of their license. I know with Connect Plus, one of the things is about releasing people to operate at the top of their license. And we've got to find ways to do that, haven't we?
Yeah. I would agree with you. I think one of the greatest problems in all our lives is, I think, for me, or my discoveries over healthcare systems, the greatest problem in life and healthcare is, if not, in fact, the greatest in anything, is that of learning the art of harmonisation and negotiation with other people.
Yes.
That
Yes.
is really the greatest problem in the world, I think.
And you're also utilizing, sorry, Richard, and you're also utilizing the untapped resource being the patient to populate some of that information that the physicians, the nurses would require to facilitate care. So yes, it's about productivity, real efficiency, which I do like. So just to talk to you about some of the risk management, when you got transformation, digital transformation at pace, we cannot have this conversation without exploring the risks involved between the trust, bringing in the technology, the patient, the recipient of the care delivered, as well as the technology company in developing these solutions. How is risk being managed in your eyes?
Decision support tools are probably paramount. I think that medicine or medical management of people is still back in the pre-Einstein world in the way we do things. I really do. I think we're still in the pre-Einstein world. Engineering, chemistry, physics, the space industry, construction is all post-Einstein world. I think what we probably have to look at is creating and implementing decision support tools to help us, as everybody else uses them around the world in decision making. And I think that that's implemented in a decision support model for patients. Now, it's not being prescriptive, it's being suggestive. But in terms of risk management, there's a very good structure inside the National Health Service in the UK for managing digital risk. And there are people who are profoundly involved in that. And I think the system works quite well in the UK and in some other countries. But if to mitigate risk, it's all about, for me, looking at the fragile working stream that you've got and better engaging with your audience and doing it in a safe and effective environment.
And there's another risk bit in here as well for me, which is about the risk of adopting new technologies and trying to find out what does and doesn't work and trying to move quickly through. And because you use the word quick 3 times in the opening minute. But that's hard in many of our organizations across Europe.
Yeah.
What's the role of pilots to your mind? What are you seeing working in the world of pilots? Because that
where we've been
into this.
I agree. Where we've been successful with digital platforms, and I thank you for this, is we've been able to, when we've sat down with a territory or an ICS, if you like, for lack of a better word, or a state in Germany, we've actually negotiated a contract where we have said, right, we will run this system parallel to your patient information system, so there's no integration issues.
Yeah,
we run it in parallel. If we can meet these particular hallmarks within this time frame you've allocated, the T's and C's on this contract mean that you'll have to acquire the system. And
Yes.
that's been the most effective way of doing it. We've actually said, because so many, I won't say trust, so many hospitals and community services organisations are dependent on pilots going for 3 or 4 years. And then at the end of it, the manufacturer just says, well, we can't support this anymore. There's no return for us.
Yeah.
You know, and a commercial model depends on a return on investment. It makes sense in our world currently. So I think what you have to do when you sit down with large ICSs, when you sit down with the top of the tree, when you sit down with the people who are making the decisions, writing the checks, the chief financial officer, the chief executive officer, the medical director, and the board, you put together a structured a set of T's and C's, terms and conditions, that stipulates that these are the hallmarks of outcomes. These are the expected this is the expected process or the due process that we're doing. This is the governance model. And from all of that, we're going to have an outcome that will mean you'll either procure the system or you won't. So so the risk is mitigated and the manufacturer has to invest in the process.
No, that's a very good approach indeed. And I guess the challenge is articulating that heavy lifting at the beginning.
It is. That's what it is.
Instead of, because you get to a point where, when do you burn your ships?
Yes, that's right. That's a good analogy. I like that.
I knew you like that, Stephen. I was just itching to say that.
That's very good. But it's true. It is knowing when to burn your ships. And I think that it's just about getting the right people at the right point and at the right place. And I think you've really got to start from the top up. Sorry, from the top down. And you've got to make the CEO meet the clinician and nut this whole thing out. And plan this whole process, dovetailing in all the various forms of management that you have to along the way. But if there's a proper contractual arrangement, honestly, it works every time. It's worked down here on the continent time and time again.
So if there's one take home for to enable clinicians, people working in the NHS and software providers to think big and act now, what would be your message going out there? Like, what can they do immediately to kickstart change?
I think they're doing it. I think there's some fabulous people in the National Health Service. I've seen that all my life, and I think that for me, for a long time, the issue has always been that it's very difficult to access the C-suite in the National Health Service, and to access it effectively, because they are distracted with so many issues, and that's not their doing. For me, the secret to success is to do the common thing, but uncommonly well. And what I mean by that is simply, if you're going to go to a CEO or the CFO on the board, you have to have all of your ducks in a line. You have to have a group of Spartans inside that facility who are going to be 100% behind you. So you've got to get rid of the time wasters.
Yes.
You've got to filter all of those people out. I mean, it's human nature. It's just what happens. Get rid of ashtrays on motorbikes. Okay.
I like that.
Work.
I like that a lot, because they do say that, particularly in health services now, we've seen it in large organizations, that power is no longer residing at the top of hierarchical structures.
Precisely.
There are these loosely connected groups with common interests that you need to engage, as you said, Spartanize them or weaponize them to support your initiative.
Yes.
Any ideas of how we can ensure that they're not only engaged but are able to follow through on the whole transformational journey?
It's political. It becomes, I think, in the first step, it's a way of, you've got to stakeholder map a site quite accurately, and you have to talk. You actually have to go in and do the old-fashioned thing of talking to people, and you have to talk to a number of clinicians and a number of middle management and senior management, and assess their insight into the problem, because there's a lot of ignorance. There's a lot of intelligence invested in ignorance. There really is. There's a lot of good intelligence inside of hospitals, but it's invested in fixed false beliefs. So what you've actually got to do is find people who can actually have the capacity to hold two opposing ideas in their head and argue it out and not be biased. So
Mm.
that's what you have to find. It's a type of person or personality. And once you've got those personalities in a line, they'll come from different walks of life. They will be different shapes and sizes, but they're there in that trust. There is intelligent life. There is a lot of very good intelligent life in the NHS. So it's
Excellent.
lines led by other people.
Excellent. So we go and seek out these
out
individuals or groups to help drive
Absolutely.
forward your transformation. Excellent.
Douglas, we're going to have to call a halt. We're at 20 minutes plus already. We've nailed it.
Really? 20
Yeah,
seconds, more like 20 seconds.
Yeah,
we just burnt our ships, and we've got the Trojans,
I love
Trojan soldiers running amok on the sandy beaches. We're okay. I get that. I get that. Stephen, it's been excellent. Every time I touch base with you, I love the analogies. You know, I was up all night thinking, okay, what can I say? Oh my God.
Well, I love the ships. I love the ships.
Yeah, that was a good one.
Yeah, but yeah, it's very insightful. And the value that you're bringing to health is phenomenal. So keep up the good work. Keep up the good work. Richard, as always, you know, we do this together. We always have these great conversations. So truly inspiring being in your company. So we catch you on the other side.
Thank you, gentlemen.
Thanks, Stephen.
Thank you for your time.
Thank you very much.
Thank
Good
you.
to see you.
Take care.
Cheers.
Cheers.
Bye-bye.
Bye-bye.
Bye-bye. Good afternoon, Richard. How are you?
Yeah, I'm very good. I'm very good. Stephen, I hope is on the way over to us now, and we can do a question and answer session with him for the next 10 minutes. So
I certainly hope so. How was that for you?
Very good. Very good. The whole thing about I loved his description about being quick. You've got to be quick, digital, yes, and doing it at people's homes. Really good. Stephen, hello there. Welcome.
Hello, Richard. Hello, Douglas. Thank you very much for doing that.
Great to have you here, and welcome from Bordeaux. I think if I've not got it right.
That's right. You are right.
Excellent stuff. Excellent stuff. Thank you so much for that. Really good conversation. We've got some questions coming in. I know one you've engaged with already, and I'll come back to that one, which is a big chunky one on AI and decision support that you started.
Absolutely.
But Kamal's asked the question: how long do you think it would take for the digital transformation to be fully functional in our NHS?
Oh, that's a political question, isn't it?
Yeah. I don't know if there are any messages from overseas that give you a clue on that, or?
Oh, yeah, actually, that's a very good point. I think that all things being equal, and with the best intentions of people, there are a lot of initiatives across the NHS right now for digital transformation. And I don't think it's going to happen I think happening on a national basis is quite challenging. So I think it will probably happen region by region, to be honest with you. That's what I see with the integrated care systems, because populations are different. And there is, if you look at the atlas of variation, there's immense variation in outcomes. So I think if you were running an integrated care system or you were part of one, you would take each app on its merit to its population. So as far as nationally is concerned, I don't know. But in terms of regionally, and in light of the new paradigm with COVID, I think it could. I think a new app could take a supplier and an ICS 12 months to adopt it.
Yeah, but that demands attacking it in the way you've described earlier.
So I've suggested, yes.
Yeah, you can't do it in the old way, can you? You have to do it in with the sort of speed and intent, and with the right stakeholders on board to make it happen at pace.
Yeah, I think the days of having a representative go in and meet surgeons, it's no longer that structure. I think now you have to approach the C-suite, and you have to get buyers on board, but it has to be a more of a holistic approach.
And Stephen, you talked about how the harmonization of negotiating human-to-human interactions. Is this a typical place where this needs take place at that state level engagement stage?
Yeah, I think harmonizations is probably the most challenging thing in the world. I think, you know, it starts off at micro level, marriage, family, and goes up to macro level. We can see that happening every night on television. But when you get to a set of interactions as complicated as a hospital or a trust or a territory, then I think you really have to sit down and map out who the network consists of and who has perhaps the most influence and the greatest interest and the greatest vested interest in the outcomes. And then you have to sit and then simply plot a plan. I mean, proper planning prevents poor performance, the 5 Ps of life. So I think that if you use that simple model of plan your territory and plan the group of people that have to be involved in the conversation, objectively or logically, then I think you're going to have greater success. Yes.
Thank you.
And that's harmonization. A plan is harmonization.
Okay, thank you. That's a big networking stakeholder management task, isn't it? In most instances.
Yeah, I think it is.
In complex organizations.
Well, I think it is, and I think that you know, Mark. I think life has changed. I mean, I think that, you know, once upon a time, I remember the old GE, good GE representatives would GE used to hang on to GE Healthcare used to hang on to people for a long time, and those particular men and women knew everybody on their patch. They knew them. They knew the janitors. They knew the guys at the door. They knew everybody, and they had built relationships that were very difficult to replace. Today, I think we're focused on the short-term gain. So I think that you have to have people in market access who are very interested in building relationships with the C-suite, and in a meaningful way. You're going to tell them, look, I'm investing in my evidence. We've never done this before, but here's a sample of it.
Absolutely. And are you also seeing across Europe that health is also encroaching in other aspects of life, and how we're going to bring that data into the, shall I say, care space now as the new paradigm that we're trying to resolve?
Yeah, I think I honestly think in a lot of respects, digitization will save healthcare. I really do. I think it'll give it to democracy, and I think it'll give it greater access. One of the many things that happens every year is healthcare systems around the world are assessed, and the NHS comes off very well on one particular point, and it's access. It has universal access. And I think that what we'll find is that digitization will be able to reduce waiting lists. It will be able to give you a remote general practitioner, not so much at a face-to-face value. It'll give you remote diagnostics. It'll enable better management of foot traffic and communications. And I also think that, you know, it's going to empower the consultant, the clinician, to make better decisions. As I mentioned earlier in the conversation, every other process in the world, complex engineering, aircraft, jet fighters, the space shuttle, the International Space Station, it all has decision support material. And I think that that's going to be an important inclusion. It's not going to be it's not going to give a doctor a diagnosis, but it's going to rule out the false positives.
Yeah, I think that leads us into Rob Lambert's question, and thanks, Rob, for this one. I'm going to pick on this. I know in chat, Stephen has answered your first question, but there's a second one. I believe AI can provide decision support tools such that the time of existing persons can be saved, changing the narrative away from understaffing towards insufficient technological support. What's preventing this from being followed up as a major program across health systems, and I guess the NHS as well today?
I think we're listening to the wrong audience. To be honest with you, I think that there's a fear, and it's what I described earlier. There's a lot of intelligence invested in ignorance. If you look at the National Health Service, we have the CSUs. There are 5 of them left, I think. And there's a rather remarkable group in, I think it's up in Lincolnshire, who have been able to marry. There's a couple of the clinical service units who have been able to marry primary and secondary data together through not just an NHS number, but through a couple of tricks they play. And those people and their work, I think, is paramount to the success of the National Health Service. In France, they've been able to do it through a digital platform. In Germany, they've been able to do it through through the private and the public. And I think that we actually have the people in the United Kingdom who can do it and are doing it, but they're doing it in a way that is being, in a way that's not, we're not approaching those people and saying, can you do this for us? They're already employed by the National Health Service. So I think the thing that's preventing us is we're not asking the right questions to the right people. I hope that answers this question.
So the data is there.
Yes.
It's manipulable, whatever that means. You can manipulate it. But we, on our side, both, I guess, the private sector, but critically, the healthcare professionals need to be asking the right questions of the people that can analyze it.
Absolutely. And I think that's half the problem. I do. So it is done in Kent, in another few regions. It's done in the HSE in Ireland. It's done very well in, it's done very well now in France. So I think that it is, I've seen it done in silos in the National Health Service. And I just think if you realise where these people exist and you brought them together, then I think it could be done. And we could definitely answer Ken's question.
Thank you. Brilliant. We are out of time, I'm afraid. We're at 32 minutes. I'm going to get in trouble with my audience and Catherine if I dare let us run over any further. Stephen, we could keep asking you questions all afternoon. I'm afraid I'm going to have to leave you to go back to Bordeaux. And for me personally, but I think for everyone, absolutely brilliant insight in terms of what's going on around the world around us. Because often we're blindsided to that, and we don't get enough sight of it, and we need that to broaden our perspective. So thanks very much.
Thank you for having me. It's been a pleasure.
Absolutely.
Thank you.
It's a pleasure. It's a pleasure, Stephen. Thank you very much.
Thanks everyone for joining us. We'll see you tomorrow. Jenny Chong from Medway
Innovation Institute, 2 o'clock. Be there.
Lovely. Thanks very much, everyone. Cheers.
Bye-bye. Is a phenomenal speaker. You know, he has that oblique angle to you know, the Marmite approach, you know, and I think we need that. If you take a look at the whole collective of people we've spoken to thus far, you know, they're got completely different personalities.
Yeah.
You know, they're not, you know, like sometimes when you do a transformation project, you have to do like a persona of who you're trying to address.
Yeah.
You know, these are all different people.
I know, different perspectives, and just having him today, you know, what have we got? We got an Australian living in France, seeing what's going on across Europe.
Yeah.
And you just go, blimey, that's a completely different perspective to what we've seen in you know, Lisa Hollins looking at NHSX. How are they invigorating, changing, or stimulating change across the NHS? You know, what can they do to stimulate it? And he's wrestling with that. But what's going on across all those borders that he talked about, even though he doesn't like borders, but he's still dealing with the cultural borders, isn't he, of different regions in different processes and systems. But I just loved it. I thought that was really good.
And thinking about the borders, just sticking with you on that one, it's very interesting. We're dealing with a pandemic that doesn't respect borders. Doesn't respect man-made borders. So there is something in that approach that needs to be really reconciled, like at top level. We're dealing with things that do not respect boundaries. And on top of that, our patients, as we were talking about earlier, we're looking to deliver care at their home, opposed to coming to the hospital. So again, it's about, if a patient decides to go up north, I was in Cumbria over the weekend, if I hurt myself, I should have access, the GP should have access to my full medical records when I'm outside of my boundary of my GP practice. So it's about wrapping care around the needs of the individual who is on the move.
So you have to go digital, don't you? And that you have to. And I think the other thing that really struck me in there was his point about making better use of our staff resources. He wasn't willing to accept there's a shortage of healthcare professionals.
Absolutely.
He was saying, no, what actually is the best use of our resources? How do we make the best use of our resources? How do we get people operating at the top of their license? And what does digital facilitate in that regard? And that line of argument is really strong. I think there's really something in there that we walk past it too often. We do fret over the shortage of people, but are we using people to the best effect?
Yeah, I think that's the excellent point, Richard, because I think it's a red herring. I do. When I was training as a nurse many moons ago, we never had any lectures on administration. Not one. Helping somebody complete an assessment form, not one.
Yeah.
However, if we know the data is suggesting that 50 to 60% of our time is spent on administrative burdens that we're not trained to do.
Yeah.
There's something for me about respect. I mean, real respect for different professions. There's a lot of very competent staff that stereotypically, are women who came through as CEOs, CCIOs through the administrative journey. They were admin clerks, and they knew tech. They had a passion for tech, and they rose up the totem pole to success, which is excellent. But that would let you know that admin is a profession that needs to be respected. You know, it needs to be. It's not an easy profession to do. It is highly complicated. So if you're getting people not trained to be administrators, you're going to get poor quality data in your system. And poor quality data in your system means poor quality outputs of that data. So being able to remove that and put the ownership back to people who will ensure that it is accurate is the game changer.
Accurate, but also done simply and easily, so it doesn't get in the way of everything else. But no, absolutely brilliant. I loved him once again.